So let's get started, guys. Bismillah ar-Rahman ar-Rahim. This is from the notes that I uploaded in the Telegram. فأنا حطيت cardiovascular medicine. جمعت تقريبا above 80 MCQs من اللي جت في الامتحان أو similar to the one that came on the exam. We will dive in. This first case is 62 years old man known to have coronary artery disease, comes to the emergency department with fainting symptoms started earlier in the day, more prominent when standing. No chest pain, no shortness of breath. He has diabetes type 2, hyperlipidemia, hypertension, blood pressure 125/70, pulse is 56, irregular, otherwise normal physical exam. ECG showed Winky Bach, a second degree type A, type 1 AV block. Which of the following are most likely to see on the ECG? A, progressive PR shortening. B, progressive lengthening of the PR interval. C, tachycardia. D, drop beat after progressive lengthening of PR interval. E, fixed 2-to-1 block.
D.
D, good. So you usually have this in Winky Bach as a drop beat after progressive lengthening of PR interval. And just give you a hint here, to differentiate between the second, when we have a second degree heart block, either is going to be Mobitz 1 or Mobitz 2. So there is a B wave QRS and a T wave, B wave QRS and a T wave, and there is a prolongation of the PR interval. The drop beat here and the drop beat here, how you differentiate, you just basically look at the PR interval after and before the drop. So here, this is the drop beat, this is the B wave, and there is a drop beat here. So we will look at this PR interval and we will look at this PR interval. If they are different, this is Winky Bach. If they are similar, this is the Mobitz 2. So you differentiate it between looking at the PR interval, the drop beat before and after. If they are the same, then this is Mobitz 2. If they're different, this is type 1. So it's like a second degree type 1 Mobitz, Winky Bach. And it's difficult sometimes to differentiate when there is a 2-to-1 block, which is there is like a QRS and there is a drop, and there is a QRS and there is a drop. The second case, we have a 45 years old woman is evaluated for severe chest pain. ECG is not, maybe you can't appreciate all, but try to work it out, guys. You usually settle in the exam. It usually comes on the exam, although the changes is settled here. Is this anterior septal MI, is this Brugada syndrome, is pericarditis, or posterior myocardial infarction?
I think.
Okay, I got another one, similar to that, though. This is much more, I guess. What do you see here, guys? The most prominent things.
Diffuse.
Diffuse is like, you can see ST elevation, like not there, but here, over here. So
Pericarditis.
yeah,
Pericarditis.
And when we look in the pericarditis, we usually look at two things on the pericarditis. The concave, you focus on the concave. It's not a convex like the MI's one, it's a concave. So it's a concave, and there is usually a PR like depression, PR segment depression, and usually appreciated in lead 2. So you focus on the examine these two things. If you found PR segment depression and a concave ST segments, and it's not like in leads, like it's widespread. So it's in the inferior lead, lateral leads, anterior leads, all. So when you see that, this is pericarditis. because you want to make sure that you don't anticoagulate these guys. So the stages that they usually pericarditis, first stage, there's a diffuse ST segment elevation. Stage 2, there is a pseudo normalization of the ST segment. And the stage 3, there is a diffuse T wave inversion with possible slightly ST segment depression. And then the stage 4 return back to normal.
Lateral MI.
Okay, a lateral MI, perfect. I just want to get rid of this. So inferior, they go in lead 2, 3, AVF, anterior septal. Let's go through examples. So this one is the lateral MI we just saw. This lead 1 and AVL, and usually on the lateral is like V6 and V1 to V6. Okay. What kind of MI this one? What do you guys think? Where is the infarction here?
Inferior.
Inferior MI. It comes in the lead 2, lead 3, AVF. So that's your left. That's your inferior. And this one?
Anterolateral.
Anterior MI, yes, anterolateral MI. This one, it's not clear, but when you see, I just want you to see on the lead V1. V1, when you see R wave in V1, this is posterior MI until proven otherwise. So anything V1, you got ST elevation or R wave, that's posterior MI until proven otherwise. Next, patient with heart failure admitted for elective surgery, started on IV fluids, post-op day 2 becomes short of breath, and he has bilateral basal crackles. How could this be prevented? Monitoring IV fluids daily, but beta blocker or calcium channel blocker.
Monitoring IV fluid.
Monitoring the IV fluid, so very important. Instead of like giving the diuretics, you give you discontinue your IV fluids if not needed. So very important things that comes in the hospital, in the ward, in the admission. We usually forget to discontinue the intravenous fluids. After the patient get well, then he overload. So it's better to assess the IV fluids, whether he needed the patient or not daily. Next, all of the following consider absolute contraindication for exercise testing, except A, left bundle branch block, B, presence of severe heart failure, C, critical aortic stenosis, D, myocarditis, E, unstable angina.
I think A.
Yeah, A, perfect. So it's not absolute contraindication, it's a relative contraindication, left bundle branch block for stress testing. In the setting of left bundle branch block, there are already repolarization abnormality limit the usefulness of the ECG. Adding imaging modalities like myocardial perfusion scanning or echo in case of left bundle branch block, that would help on defining whether the patient is having ischemia or not. Sometimes your baseline also, when you have LV hypertrophy, also you would have repolarization and you would have ST changes, or if you have a interventricular conduction delay or pace rhythm or pre-excitation, those ones, or digoxin toxicity, all those things that you would have to have an myocardial perfusion scanning or an stress echocardiogram. Patient presented with chest pain for 2 hours. ECG, T-wave inversion, troponin is high. What's the diagnosis? STEMI, non-STEMI, unstable angina, or stable angina?
In STEMI.
Non-STEMI, yes. So when you have a positive markers, like positive biomarkers, strobes on CK, and you have ST without ST elevation or ST equivalent. Very important, ST equivalent we know. So ST equivalent means either a new left bundle branch block or a posterior MI. As we said, a tall R wave in V1 to V3 with ST depression. That would indicate this is equivalent to ST elevation, those two things. If there is a new left bundle branch block, that's considered to be like, if you have a new left bundle branch block with the positive biomarkers, this is MI. And the STEMI, you diagnose STEMI if you have an ST elevation 1 millimeter in 2 consecutive leads with the positive biomarkers. Unstable angina, they would have normal cardiac biomarkers, but they would have non-specific ST changes, maybe ST segment depression or T wave inversion. Stable angina is that there is no ECG changes, biomarkers is normal, it's just like a typical angina. A 60-year-old man admitted to the coronary care unit with an acute myocardial infarction. His hemodynamic parameters, 2 hours later, blood pressure 80/50, heart rate is 40, oxygen saturation 95. Which of the following would be appropriate management? A, IV atropine, or normal saline, or IV isoproterenol, or dobutamine?
Dobutamine.
Atropine.
Atropine, yes, that's your first things to do. This is from up to date I brought for you guys there. So the initial management for patient post MI conduction abnormality depends on the location of the MI and the severity and also the hemodynamic instability. Patient with inferior MI and a 2nd degree AV block or a high grade AV block or a 3rd degree complete AV block, if they are hemodynamically unstable, should urgently be treated with atropine first. If the hemodynamically instability persists even after you give the atropine, then you would do the temporary cardiac pacing, either transcutaneous or transvenous. In general, beta agonists like dopamine, epinephrine, dobutamine should be avoided in hypotensive patients with MI. An AV block. Why? Because it will worsening the ischemia. For patients with a high-grade AV block associated with inferior MI, aminophylline may improve AV conduction and symptoms. Additionally, in the setting of the MI, myocardial ischemia, acute myocardial ischemia patient should undergo prompt revascularization, very important. And they bring that one in the exam, like they will give you like a patient typical and they show you Winky Puff or 2nd degree or a 3rd degree on the exam, and your choice would be first revascularization if there is revascularization. Following revascularization, most conduction abnormality will improve and resolve, do not require a pacemaker. And the isoproterenol was actually not anymore in the ACLS. It's substituted by epinephrine or dopamine. Which of the following is not contraindication to use TPA in MI? A, blood pressure more than 180/110. B, non-compressive vascular puncture, like a subclavian line, or major surgery within 3 weeks, or menstrual bleeding.
D. That's true.
Yeah, it's not a contraindication. So menstrual bleeding is not absolute contraindication. These are the absolute contraindication for thrombolytic, any prior intracranial hemorrhage, no structural cerebral vascular lesion, no intracranial neoplasm, ischemic stroke within 3 months, except acute stroke within 4.5 hours, suspected aortic dissection, active internal bleeding, except menstrual bleeding, significant closed head or facial trauma within 3 months, intracranial or intraspinal surgery within 2 months, severe uncontrolled hypertension, unresponsive to emergency treatment. For streptokinase, prior treatment with within the previous 6 months is also absolute contraindication. Elderly patient, asymptomatic, came for a checkup and you found that you have aortic stenosis murmur. Aortic valve gradient is 40. What do you do next? A, follow-up, B, surgery for valve replacement, or C, valvoplasty? Any thoughts on this one? Always comes this aortic stenosis indication for surgery. What do? You do surgery or follow-up, or you do just valvoplasty?
Maybe follow-up.
Okay, maybe follow-up. Okay, for the for severe aortic stenosis, so we define severe aortic stenosis, the valve area less than 1 centimeter, a square centimeter, or the mean transvalvular gradient more than 40 millimeter of mercury. In the absence of symptom, patients have low risk for death, and this patients have no indication for transcutaneous aortic valve replacement. So what are the indication for aortic valve replacement in severe aortic stenosis? Here's the one that you should know. Any symptoms, so if you have dyspnea, angina, presyncope, syncope, that's an indication for valve replacement. If they have LV dysfunction, ejection fraction less than 50%, in asymptomatic patients, you do the surgery. Or if they have a concomitant cardiac surgery procedure for another indication, such as like coronary artery bypass grafting, or a surgery for ascending aortic surgery, so you would do the valve replacement with it. And the aortic valve replacement may be considered in asymptomatic patients with abnormal results or supervised exercise testing, such as those with a poor exercise tolerance or abnormal ECG changes or hypotensive during the test. The surgical aortic valve replacement is recommended for symptomatic patients at a low operative risk. If they have low operative risk, you would go with the surgical, but if they have like a high operative risk, you would do with the transcatheter aortic valve replacement, TARV. And it has a survival benefit similar to the surgical aortic valve replacement for intermediate risk and for the high risk patients, and is superior to medical therapy and non-surgical candidate. What are the contraindication for the transcatheter aortic valve replacement? If you have bicuspid aortic valve or significant aortic regurgitation or mitral valve disease, these are contraindication for your transcatheter aortic valve replacement. A 62-year-old male with idiopathic subvalvular hypertrophic aortic stenosis going for dental surgery. A, risk of endocarditis is 50%, B, risk of endocarditis 12%, C, prophylactic antibiotic is not needed, D, after procedure antibiotic is sufficient. So which one is correct?
C, not needed.
C. Yeah, he doesn't need prophylactic antibiotics. Oh, so provide prophylaxis for infective endocarditis only in patients with the highest risk, and that include prosthetic cardiac valve, history of infective endocarditis, or unrepaired cyanotic congenital heart disease.
What's the name of the app you want to launch?
Or repaired congenital heart defect with prosthesis or shunt less than 6 months post-procedure, or residual defect. Valvopathy following a cardiac transplantation, or prosthetic material used for cardiac valve repair. Like there is some like a prosthetic material on the valve itself. Those are the highest risk for infective endocarditis, and that would require antibiotic prophylaxis. Otherwise, no. Only the prophylaxis is only indicated in the highest risk procedure, Which procedure is highest risk procedure? Dental procedures involving mucosal bleeding. There is a mucosal bleeding that's the highest risk procedure. A procedure that involves incision or biopsy of respiratory mucosa. Procedure patients ongoing GI or GU tract infection. Procedure on infected skin, skin sutures, musculoskeletal tissue. Surgery to place prosthetic heart valve or prosthetic intravascular or intracardiac material. Most patients require prophylaxis will be undergoing dental procedure and indicated antibiotics, either oral amoxicillin, 30 minutes or 60 minutes before the procedure. If they're allergic to penicillin, you would use your cephalexin or azithromycin, clarithromycin, or clindamycin. Patient has hypertension, diabetes, peripheral artery disease, and coronary artery disease. He's stable on ACE, clopidogrel, aspirin, and insulin. LDL and triglyceride are normal. Which drug to be added? Beta blocker, calcium channel blocker, atorvastatin, losartan.
Maybe A.
Yeah, this is very important. Like for here, just the peripheral artery disease. Peripheral artery disease is we need a statin on board for this patient. He has to have a statin. He has too many. Like if you can just see he has coronary artery disease, diabetes. He's not on statin. He has to be in statin. Why? Statins remains the cornerstone for lipid management for secondary prevention. And it has been shown that reduces MI, death, and stroke, even if they have a normal LDL. You have to put them on the high intensity statin therapy because these patients are high risk patients. And I brought this one quotes from the American College of Physician Journal, the review. There was a good review article on this one. And they stated for the statins, high intensity statin medication are recommended for all patients, regardless of their LDL level. For all patients with peripheral artery disease on basis of most recent ACC and AHA guidelines. And they quoted also here, patients with peripheral artery disease should be prescribed a high intensity statin to reduce the risk of cardiovascular events. In most studies, the rate of statin prescription were less than 75%. So we're not doing a good job with prescribing the statin for peripheral artery disease, which emphasizes the importance of maximizing medical therapy among high-risk group of patients with advanced atherosclerotic disease. This is usually comes in your exam, guys, and you saw lots of questions on the peripheral vascular disease, like option of management. So what are the things that decrease the risk of MI, stroke, CV death, cardiovascular death? Is one, you discontinue the tobacco use, walking program or a supervised exercise program, very important. And that's the one they usually look on the exam. So I saw one of the questions, they put it together, smoking cessation or walking program. I would go with the walking program or the supervised exercise program. Also controlling blood pressure to the goal with ACE inhibitor and high dose statin therapy and antiplatelet therapy. All those measures would decrease the risk of MI, stroke, and cardiovascular death. What things improve symptoms of peripheral? Sorry? Things that improve symptoms in peripheral artery disease, will improve quality of life and prevent amputation, discontinuing of the tobacco use, walking program, and silestazole, and good foot care, and revascularization. At 50 years old, women with Marfan syndrome present with substernal chest pain radiating to the back. Physical exam revealed 2 out of 6 early diastolic murmur. ECG was obtained. What is the diagnostic study would you obtain first? Echocardiogram, CT, angio for the chest, cardiac catheterization, VQ scan, or vasodilator SPECT scan.
I think it is a transthoracic echocardiogram.
What does this patient has from the ECG and from the what?
Yeah. Marfan always associated with the aortic dissection.
Okay, so how you confer aortic dissection?
B, maybe.
Yeah, computer tomography angiography. You have to have an angiogram for this patient's aortic dissection. As you said, like substernal chest pain radiated to the back with the new diastolic murmur. And the risk factor would be connective tissue disease, hypertension, smoking, atherosclerosis, pregnancy or trauma, or a pre-existing aortic aneurysm, like this patients have Marfan syndrome. Patient with posterior inferior myocardial infarction. Few hours developed hypotension and raised JVP with a clear lungs on auscultation. What does he have? Right ventricular infarction, lateral MI,
Cardiac tamponade.
OC, cardiac tamponade.
A, right ventricular.
Always when you have like posterior inferior, you know that there is a right ventricular infarction. So anything like they said, posterior inferior MI, that's almost always like would affect your right ventricle, and they would have JVP with the clear lungs. So the classical triad for right ventricular infarction would include JVP distended and clear lungs, very important, clear lungs and hypotension. Infrequent clinical manifestation include right ventricular third or fourth heart sounds, which typically audible on the left sternal border, increase with inspiration. A right ventricular MI, isolated right ventricular myocardial infarction is rare. More commonly occur with the inferior wall myocardial infarction, occurring in about like 30 to 50% of such cases. Approximately 50% of patients with the right ventricular myocardial infarction have profound hemodynamic instability and usually hypotensive. And the prognosis is usually very good. These are just some things that you would just to avoid. When you have a right ventricular infarction, avoid nitrates because that would make them hypotensive. Diuretics, they are like reload dependent, so you want to give them fluids actually, and avoid also morphine. Anything would lower your blood pressure, you want to avoid. And you want to maintain the AV synchrony. AV sequential pacing for complete heart block you may need, and cardioversion for atrial fibrillation, and inotrope support, like dobutamine, if cardiac output does not respond to the volume loading. If they have at the same time LV dysfunction, then you may consider intra-aortic balloon pump, or you would consider like vasodilator or perfusion or thrombolytic therapy. Which of the following indicate cholesterol emboli? Red cell cast, granular cast, eosinophiliuria.
They see eosinophiliuria.
Yes. So eosinophiliuria is usually indicated of a cholesterol emboli, but it's not almost always. You can have that eosinophiliuria in acute interstitial nephritis. All patients with a history of heart failure with dilated cardiomyopathy and atrial fibrillation. What is the most appropriate management to control his heart rate? Propranolol, dialtism, or verapamil, or digoxin?
Going with the digoxin C.
Yes, digoxin. So digoxin remains the one of the most frequent prescribed drug for management of atrial fibrillation, and the main indication for digoxin atrial fibrillation is restoration of the sinus rhythm and a prevention of recurrence and slowing the ventricular rate. And just this is like, if you have an AFib, and you would say, first question, is this patient hemodynamically stable or not? If they're not hemodynamically stable, then you want to immediate cardivert them. If they are stable, then you want to rate control them, and you want to define the duration of the atrial fibrillation. Whether it's more than 48 hours, if it's more than 48 hours, yes. So you would do TEE and rule out the thrombus, and after that you can, there is no thrombus, you can cardivert. And if the or you can do anticoagulation for 3 weeks and you can cardivert. But if the duration of atrial fibrillation not more than 48 hours, then you cardivert them. Mechanic comes to you in clinic complaining of shortness of breath during exertion. However, he is able to continue his work as the symptoms go away when he rests. Which class he's in New York Heart Association? Class 1, class 2, class 3, or class 4?
Class 2, B.
Class 2, yeah.
Yes, perfect. So you got that one, guys. So you are caring for a 26-year-old man with dyslipidemia, family history of early coronary artery disease, and the laboratory analysis reveals that the low HDL, which of the following intervention would raise his HDL level the greatest extent? Eating oat, which one?
C.
C, starts exercising?
I think so.
Perfect. So these are the measures to increase your HDL level, HDL cholesterol level. Aerobic exercise, stop smoking. They're similar pretty much, but the exercise is more beneficial. Losing weight and also healthy diet. Which of the following is the most common clinical presentation for acute rheumatic fever? Carditis, chorea, erythema marginatum, polyarthritis, or subcutaneous nodules?
I think it is polyarthritis, D.
Okay, yeah, so the acute rheumatic fever is almost universal due to group A streptococcus disease, and the polyarthritis present in 60 to 75% of the cases, while the carditis present in 50 to 60% of the cases, and the chorea 2 to 30% of the cases. Patient present with MI 2 hours ago, and it's an anterolateral on ECG. PCI is not available. What do you do? Aspirin, streptokinase, heparin, and beta blocker, or aspirin, streptokinase, nitroglycerin, and beta blocker?
Maybe A.
So you want to do with the aspirin, streptokinase, heparin, and beta blocker. We'll just review what you do for the MI patients. So aspirin as soon as possible for all patients, and they continue indefinite. Thrombolytic therapy, you administer, like if it's the BCI is not available, you would administer it. And the anticoagulation, that's what it is there. So you would use either unfractionated heparin or low molecular heparin or biliverdin. So as soon as possible. And a beta blocker for sure, and nitroglycerin. All of the following ECG waves forms are matched correctly. Cardiac cycle, that they represent, except one is wrong here. B wave or atrial repolarization, BR interval, atrial repolarization, QRS complex, ventricular depolarization, T wave, ventricular repolarization, U wave is ventricular repolarization. A. So the correct is like a depolarization, not repolarization, the B wave. It is an old male with a history of chronic retrosternal chest pain, exerginal dyspnea. After 3 weeks, he started to complain about the same problem, but this is now on the sitting. While he was sitting, he would have
Unstable angina.
yes, so it's a kind of growing. Unstable angina is like very important. Yes, it's like would have a like in sitting position. You don't have to exert yourself, and when it's with the exertion, that's typical angina. But with unstable, it's angina, unstable angina. Here I given away that question, but a 77 years old female preoperative evaluation before resection of a sigmoid colon for recurrent diverticulitis, scheduled after 5 days, known non-valvular aortic atrial fibrillation on warfarin, hypertensive and on chlorothalidone, which is like hydrochlorothiazide similar, metoprolol, and the exam, the INR is like normal, and the INR is 2.3 and CHAD score is 4. In addition to withholding warfarin before surgery, which of the following is the most appropriate management patient preoperative anticoagulation? Aspirin, enoxaparin, unfractionated heparin, or no additional intervention? So basically, atrial fibrillation patients and is going for surgery. Do you anticoagulate preoperatively, or what do you do like during like the period that they will do the surgery and they, you know?
I'm going with D, no additional interventions.
Yeah, no additional intervention. We only do bridging. We do bridging, like mean we would anticoagulate, like stop warfarin and put them in heparin only for the highest risk thromboembolism. Like if they said atrial fibrillation with mitral stenosis, that's a higher risk. I got. Okay, this is a 67 years old woman in the emergency department with 1 hour history of chest pain. Has a history of hypertension, diabetes on metformin, quinapril, and aspirin. Blood pressure 95/60, pulse is 50, with no evidence of pulmonary or peripheral edema. Positive troponin, and this is the ECG. Which of the following is the most appropriate next step management on this management of this patient's arrhythmia? A, cardiac catheterization. B, echocardiogram. C, permanent pacemaker implantation. Or D, temporary pacing.
B.
We just mentioned it on the first slides, if you remember, guys, the Winky path. So this ECG is like, if you look here, there is a drop. There is a drop QRS, and if you look after and before this BR interval, and this PR interval. They are different. So this is like a second degree, winky path. Yeah, so it's like a heart block. It's a heart block with MI, the same things. So we said, you don't need to do pacing on all these things. You just need to send patient for cardiac cath. And if they did the, fix the blockage there, it will become normal. You don't need to have, you don't need to do pacing or all this. So you just send the patient through cardiac catheterization. So this patient has Mopitz type 1, second degree AV block with evidence of acute coronary syndrome. He should undergo a cardiac catheterization for emergent revascularization. This patient, chest pain, ST segment elevation, and elevated troponin indicate MI. ECG showed this winky path. So the treatment would you would go with the revascularization actually.
Then, doctor, what is indication for pacing, temporary or permanent pacing in such patients?
Okay, it's a good question. So, here maybe it was like permanent or temporary pacemaker placement is not required in this case because of the patient does not have any symptoms. So if he has symptoms, yes, you would put like a temporary, you would give, like as we said, the first one on that questions, we give atropine, and if it's not responding, then you would go with your pacing, temporary pacing. So symptoms are important and hemodynamic unstable. Yes, those ones are the indication for you. You would do your temporary pacing. So you look for those two things. If symptomatic or advanced conduction defect like persist, like after we do the revascularization, the patients still have the second degree after. So yes, this is recommended. You would do the pacemaker implementation after like revascularization. Other indication, if you have like a complete heart block. But all these in the setting of MI, acute coronary syndrome, you want to fix the acute coronary syndrome first. If the acute coronary syndrome is not present, like the patient just presenting with third degree heart block, of course you're going to put a pacemaker. Like he's like a third degree heart block. Maybe he had a pre-syncope or something where he feel fatigue. So they're high grade, yes. But if they have like a reason, like they have a cause for that, like this patient has an MI, has an acute coronary syndrome. So you want to fix the acute coronary syndrome first. And after that, you will see if the heart block is still persisting, yes, you would do a pacemaker. But if it's resolved, it's resolved. That clear?
Clear, doctor.
Okay. And this one we come through with this question. Yeah, this one comes in your exam and every exam, almost always. 33 years old, male patient with 1 week retrosternal chest pain radiated to the neck. Pain started 3 weeks ago after upper respiratory tract infection. Pain is worsening when he's lying down and relieved when he's sitting up. Exam systolic rub best when he leans forward. The ECG showed non-specific ST changes. Which of the following is the treatment of the most appropriate treatment for this patient? A, ibuprofen. B, prednisone with oseltamivir. Or C, prednisone. Or D, prednisone and colchicine. E, ibuprofen with colchicine. So basically pericarditis patient. How do you treat it?
Ibuprofen.
Which one?
Ibuprofen.
Ibuprofen.
E.
A. So the new recommendation, not only NSAID, guys, you have to add that colchicine with it. E. So you have to put the colchicine with it. So management of viral pericarditis, now they change it. Before, we used to give just the non-steroidal anti-inflammatory drugs. That's it. But now the new studies and the new recommendation, no. So that's the reason they bring it in the exam, because it's the new recommendation. You give both non-steroidal anti-inflammatory drugs like ibuprofen, as well as with your colchicine. So don't forget colchicine for pericarditis, very important.
Doctor, we use it for future protection, right? The colchicine. What is it? Why we use it?
Okay, it's why we use it. First of all, it's a very good an anti-inflammatory, and it would like why it would prevent the pericardial thickening. You know, some patients would have a pericardial thickening that they would go to complication of like constrictive pericarditis after a few years if they have recurrent pericarditis. So it's good to start it from the beginning to prevent like a complication like constrictive pericarditis in the future.
Clear, thank you.
Okay, that's all for today, guys. Thanks for your for listening. Thanks a lot. Inshallah, we'll have another section, and I will highlight on the because they did have the some question added on that note. So I will. There is one only questions there. I think there was a mistake on it, but I will show it inshallah on the next session if there is anything. And if you guys have any questions, we will open the group so you guys can have more questions for me and suggestion too.
Thank you, Doctor. Doctor, could we have the presentation?
Oh yeah, all these lectures are actually will be uploaded, and also the presentation.
Thank you.
All I will upload it on the channel. All. Thank you, and رمضان كريم وكل عام وانتم بخير والله يتقبل منا ومنكم ان شاء الله يا رب.
اللهم امين يا رب. شكرا دكتور.
حياكم الله.
شكرا دكتور، يعطيك العافيه.
يا معكم الله يعافيكم ان شاء الله.